All right, well, welcome everybody to our virtual office hours. It is presented by the Southwest Telehealth Resource Center. It is also presented by the Northwest Regional Telehealth Resource Center, the Arizona Telemedicine Program, and most importantly, the Arizona Department of Health Services. So without further ado, again, this is supposed to be an interactive session. Trudy Bearden is going to be our speaker, and she's going to go over some information for you, and then we're going to open it up for questions. So hopefully start writing them down or put them in chat. That's how we're going to get them. And depending on the size of the number of people, we can actually ask and answer live. So Trudy, I'm handing it over to you. Welcome, everyone.
Great. Thank you. So I don't know about you, but I've been seeing a lot of webinars about the calendar year 2022 physician fee schedule proposed rule, and they have all been excellent. And I think a lot of them have made the call to action to submit your comments. Unfortunately, that deadline of September 13th has come and gone, but that doesn't mean that you shouldn't think about submitting comments whenever there are interim rules that are promulgated, or to get in the habit of reading the proposed rule on a regular basis. I started reading the proposed and final rules starting in 2010. So I have read the proposed and final rules for the past 11 years now. And you'll see on that bottom right-hand corner what looks like a really great breakfast and then a snapshot of the proposed rule. And my colleague, Dr. Sarah Woolsey, says, Trudy eats proposed rules for breakfast. And I must say that that crepe looks far more appetizing than a proposed rule, but I really do dive into them, and I dive in deeply. And back in 2010, I was primarily focused on the changes for the EHR incentive program, or more affectionately known as meaningful use. And for 4 years, I co-led the Meaningful Use Burning Issues work group. And for those 4 years, we had a dedicated CMS policy analyst to help us with providing what they called sub-regulatory guidance. Reading between the lines, what that meant was sometimes what was in the proposed and final rules wasn't quite clear, and people had a lot of follow-up questions. They were very anxious because a lot of money was at stake, and if you were audited, you were going to have to pay your meaningful use money back. And I learned from talking to those policy analysts. We also had a representative from the Office of the National Coordinator who would help us answer questions. And what I learned from them is behind the scenes that CMS really does take your comments seriously. They love hearing from the front lines of healthcare service delivery. They address every single one of them. So to make this maybe a little bit different than those other proposed rule webinars, let's just take a short little trip down the rules and the comments 101. I have prepared comments back to CMS in the past 11 years, several times over. And because of that experience at my organization, CoMagin Health, we are the CMS designated quality improvement organization for 6 states. I sometimes lead our gathering stakeholders together because we want to hear from other people who are at the front lines doing healthcare service delivery, like the Medicare Diabetes Prevention Program. So there's there's a big change in this proposed rule around that. And last year there were some huge changes. And what I do is I do what I like to do for breakfast, and I read the proposed rule really, really carefully. And what I do is call out what are the things that we need to comment on, and I'll copy and paste and cite the pieces of the proposed rule, and I make it easy so that people, our stakeholders and people that we meet with and solicit comments from, don't have to read that 804 pages of 3 font and a bazillion columns. So I think that there are opportunities for us to commit to preparing responses to CMS. But if we're going to talk to other people, you know, making it as easy as possible. And then we'll touch on some of the upcoming proposed changes, and then I hope we can have some nice discussion. So how does the calendar year XYZ physician fee schedule proposed rule and final rules work? So every year around July, everybody is kind of waiting with bated breath, like, when are they going to release it? When are they going to release it? So it's usually released in July. And when it's first released, it's like double space, and it's really, really long. And then they publish it in the Federal Register, and that's when it shrinks to that 8 font with, you know, the columns. And then 60 days after the proposed rule is released, comments are due, and that's usually around September. So this year it was September 13th. And then the final rule is usually released in November. So in this November, we will be looking for the calendar year 2022 physician fee schedule final rule. And the rules that are promulgated in that document go into effect January 1 of the next year. And, you know, there are all kinds of summaries and cheat sheets that come out. But if you go to the proposed rule, CMS includes the background for some codes. So for example, if you go to the most recent one and you go to the section on the chronic care management codes, there's a whole history of like when they were released, so on and so forth. And it's really fascinating to kind of see the background and the thought process that CMS has when they put these rules together. And you know, if you take somebody's cheat sheet, you kind of miss that detail that I think is really important. Of course, I do have to recognize that I'm a little bit nerdy, so you know, take that with a grain of salt. In this proposed rule, they cover how to make chronic pain management easier and to use virtual services to do that. And when I read it, I think there were about 4 pages covering that topic. There was like a half a page that was actually what they were going to do. The rest was the history, the Support Act, all kinds of really interesting information that kind of went into why they finally got to this point of making this change. So what I do is I kind of ignore all the cheat sheets coming through, and I allocate some time, uninterrupted time, and I really just dive into the proposed rule. And you know, it's not that bad, I promise you. So how will you know when the rules are released? So if you subscribe to the CMS electronic mailing list, you'll be in the know. And what I do is I actually subscribe to the MLN, the Medicare Learning Network list as well. And I get an email and it'll say, oh, it's been released and here's the link. And make sure that you download and save the version of the rule that's posted in the Federal Register. I'll show you in a second kind of how it looks. And then when I do that first read through, I have 2 screens, and on my other screen, I start taking notes about the sections that interest me. So yeah, this proposed rule is 804 pages, but you know what? I probably only care about 25 of those pages. So I don't even look at the other stuff. I just hone into what is coming down the pike. And in the lower right-hand corner, you'll see the hierarchy of how the proposed and final rules work. So they have like a Roman numeral 1 with the major title or the topic, then a big letter for the subtopic, and then a number, and then a small letter, et cetera, et cetera. So I feel like it's kind of like nesting dolls is how I look at it. So when the before it's published in the Federal Register, you can see that there are 1,747 pages and it's just double spaced. But then it gets published in the Federal Register and you can see the font is really tiny and there are 3 columns and it really shrinks it to 804 pages. So not so bad. So what are the other steps that you can do to dive in and hopefully possibly submit comments back? Use the highlight feature in Adobe. So let's see, I could show you real quick kind of what it looks like. Here's what the proposed rule looks like. I use Control F all the time. Let's say I want to look for what's telehealth related. Takes a little while to get there because it's a big document, but you can see that anything that interests me, I highlight in yellow. So then if I'm scrolling through, I will really zone in on what the pieces are that interest me. And what drives me nuts when I read it, and they'll say, in reference to CFR 410.710, I'm like, I don't know what that is. So I sometimes have to Google them, and it does drive me a little bit nuts. In this particular one, there are a lot of references to the Consolidated Appropriations Act, or the CAA. And so I had to have that up. I would go to the CAA, and then the CAA would reference the Code of Federal Regulations, or the CFR. So, you know, sometimes I was just on the hunt. And when I put together the cheat sheet for our stakeholders, what I would do is when I found that information, I would put it in the Word document that we sent out with a hyperlink to that, so they wouldn't have to go do this whole same treasure hunt that I did. And decide if you'll submit comments. It's really, really easy. So on the first page of the proposed rule, they tell you how you can do it. You can fax, you can mail, or you can do it electronically. Like, why would you do anything other than electronic? But it's really easy peasy. And, you know, is it going to be just you, or are you going to submit to a group of individuals or stakeholders? At CoMagin Health, when we submit comments, we have a table at the bottom, an appendix of all of the people who submit. And even though we have stakeholders that we put together, sometimes they have to get permission from their organization. And so we're always very, very careful with that table. And like I said, make it easy. And what we've done is, instead of asking people, what comments do you have, we schedule a meeting with our stakeholders and they tell us what they think, and we capture it in the document. We get a finalized version, we send it out to them. And I am just always so surprised at all of the amazing input that they have. And I'm a big fan of the wisdom of the crowd. I will say that some organizations will try to do, I don't know, they try to get as many submissions as possible. So this is the American Psychological Association. And so they must have sent this template out. And if you go and you look at the comments, there are hundreds of these that are just kind of a cut and paste. People fill in their what they are, where they live, and apparently somebody submitted this one but forgot to say who they were. So this is just a screenshot of you know, what it looks like. And I don't know, maybe 8 years ago, there was a really contentious issue with meaningful use and some of the clinical quality measures that were going to be required. And some organization did this kind of mass comment thing, and there were 600 comments that were submitted that were exactly the same thing. Like, I don't know, does CMS look at the preponderance of the submissions on a particular topic? I'm not sure. I'm not sure it's the best approach. I think it should be individualized and be specific, but that's my opinion. You have to refer to the regulation title and the CMS number so that they know what you're talking about. I've seen some comments submitted and I think to myself, CMS is not going to have any idea what you're talking about. So you have to be really careful about what it is that you are actually referring to. And I can show you really quickly kind of what that looks like. So, you know, you have what they recommend, and then you, this is actually our cheat sheet, and then you put the comments. You can put your comments in. We support dropping the language requiring the treating physician to place the referral. We request CMS consider other non-physician practitioners be allowed to refer as well. Oh, by the way, this is for medical nutrition therapy. So for this one, CMS is proposing for referring patients for medical nutrition therapy instead of the treating physician. They're going to change it to the physician. So nurse practitioners, physician assistants cannot refer for MNT. I'm a physician assistant. I can prescribe a Schedule II controlled substance, but I can't order MNT for an individual with diabetes or chronic kidney disease. And so we would love them to change that. We commented on that. It's not in the proposed rule, so they will ignore that comment, but probably made us feel a little bit better just to make mention of it. So just a quick word about telehealth codes and the proposed rule. So there are Category 1 and Category 2 codes. I always think of those as the permanent ones. So if you go to, if in 2019 you went to the CMS list of telehealth codes, those are the Category 1 and the Category 2 codes. And even though people submitted for some of these codes, they found that none of them were worthy, and they did not decide to add any Category 1 or Category 2 services to the Medicare telehealth services list. There are the interim codes. Those are going to be available through the end of the public health emergency, and there were also no new codes added to the interim list. We may see those added between now and the end of the public health emergency. I'm just not sure. And then there are the Category 3 codes. So those were the codes that were, there used to not be a Category 3. Category 3 codes were started due to the pandemic, and they added these Category 3 codes, and they're proposing to keep those codes until the end of calendar year 2023. So December 31st, 2023, we will also have the Category 3 codes at our disposal, and Medicare will note which ones we use, and if there's a high uptake of certain codes, I think that will make it more likely to be added to the permanent list or have it be converted to a Category 1 or a Category 2 code. And, you know, so I think it's worthwhile to take a look at what the Category 3 codes. It's a little confusing in the list to, you know, figure out which ones are the Category 3 codes, because in the Medicare telehealth Excel spreadsheet that everybody knows and loves, it doesn't say Category 3. So we'll see. So one of the most important, so I work with a lot of health centers. So for me, this one is really important, and rather than create a slide with all of this information, I'm just going to show you the excerpt that we used for our submission. So it's under the Rural RHC and FQHC Telecommunications Technology. So, and I do expect them to make this into, to make it into the final rule. I don't think anyone's going to say, hey, you can't do that or you shouldn't do that. So they propose to, oopsie daisy. So they're proposing to revise the regulatory requirement that an RHC or FQHC mental health visit must be face-to-face. So they can't say RHCs and FQHCs can be distance sites, which would be amazing. We do have legislation that's pending, but hopefully it'll do that, several pieces of it, as most of the people on this call probably know. So they can say that mental health visits don't have to be in person. And so they're saying we're gonna revise the regulatory requirement, which will be great. but only when furnishing services for the purposes of diagnosis, evaluation, or treatment of a mental health disorder, which is so important. We have such a shortage for mental health services, and it's just going to get worse as we see the effects of long COVID. They're also proposing to allow RHCs and FQHCs to furnish those mental health visits using audio only, which is key. So CMS has noted that a lot of mental health services have been by audio only, and they see the need to continue it. And then to allow payment for those mental health visits the same way that RHCs or FQHCs receive their payment. So for RHCs, it's the all-inclusive rate, and for FQHCs, it's that prospective payment system. So they built in, how are we going to reimburse them for that? So that's great. And then they propose appending the 95 modifier to show that the service was furnished using audio only. And, we support that because it will allow CMS to collect data on the high uptake of these services. And then, as everyone knows, there's this 6-month requirement for mental health services as part of the Consolidated Appropriations Act. So if you're going to provide mental health services, you have to have seen, for an initiation of those services, you have to have seen the patient in the past 6 months. And then for subsequent visits, CMS is proposing the interval for those in-person visits. And what they're saying here is that what we're saying is that for those audio-only mental health visits, we also want to have that requirement for the in-person visit, but it might be especially burdensome. Oh, yes, it is going to be especially burdensome. Please, please, please don't do that. So we'll see whether they do that. Right. So for my placeholder, I put a picture from a run that I did the other day because we almost never see mist in our mountains. All right, so I have not been paying attention to chat. So Chris and Elizabeth, I'm going to pause here. Any questions that we should stop and address, or comments or feedback or input?
Let's see. So far, most of them have been about just links and stuff. So no, we're good.
Okay.
Keep going.
Cool. All right. So yes. So many people are so upset that CMS in the proposed rule is implementing the Consolidated Appropriations Act provisions. I think it was actually on a webinar or an office hours that I did for the Southwest Telehealth Resource Center, where this came up, and people were just, really up in arms about this. But this is when the alarm was going off, and people were going, oh my gosh, wait a second. I honestly don't know how, if anyone knows how this got into the CAA, please speak up and let us all know on the call. It makes absolutely no sense. I mean, if you're using telehealth to have this 6-month visit, in-person visit 6 months before the date of the first telehealth service and then ongoing, it makes no sense. I mean, if you are a state like Nevada, for example, that has a dearth of mental health providers, and you want to use out-of-state providers, like how, it just isn't going to work, because if you have somebody from California providing mental health services to Nevadans, how is that patient going to have an in-person visit with that California mental health provider? I don't know I don't know the genesis of this, and it just, to me, makes absolutely zero sense. And, there's this clarification from the CAA that says this subparagraph shall not apply if payment would otherwise be allowed under this paragraph, which I honestly don't know what that means. Like, how, I'm a clinician, I'm very much about operations. Like, how do we operationalize this, and how do we make sense to our clinicians and our patients? I'm just not sure. So for me, it's a big question mark, and I'm so disappointed that this is even coming down the pike. But we have to be careful not to, and oh my gosh, there are so many comments in the submitted about this. But CMS, it's my understanding that they don't have a choice. They have to implement the CAA provisions. The other thing that I don't know is how this impacts state Medicaid agencies. So the other thing that I hope this webinar would do differently than the other kind of awesome proposed rule webinars is think about what we need to do now. So this is probably going to go through. So if you are a telehealth provider or you're a clinic, how are you going to deal with this? What came to mind was, how are you going to get around this? But I probably ought not to say that. But how are we going to comply with this in a way that provides services, continuation of services as best we can, and then also complies with these requirements? So it's really tough. So I do like that CMS is going to amend the regulations to allow the home of a beneficiary as an originating site for mental health services on or after the first day after the end of the public health emergency. So we have a waiver in place for that now. This kind of makes it permanent. Right? Woohoo, CMS. Yeah, so they're also going to require that in-person non-telehealth visit, which just sticks in my craw. And if you are going to be providing, these services to somebody in the home, and you are going to be doing them by audio only, that's fine, but you have to have the capacity, but only use audio only if the patient says, I can't, or I don't want to, or I don't have access to two-way audio video technology, which is, complies with CMS's definition of telehealth. So this piece too is really important. I really love that CMS is going to keep the flexibilities for direct supervision requirements. For 5 years, I managed a family medicine residency, and I'm in rural Idaho, and getting preceptors who can come on site, where these are often physicians who have their own practices who are losing revenue because they have to come to the residency program. I'm really hoping that this is an option for residency programs. I'm a physician assistant, so I always have to have a supervising physician. If I was practicing in a rural area, a lot of rural areas can't afford a physician to be on site. And so having this capability of having the virtual presence of the supervising physician, amazing. Yes, we need to keep it. And I think that this will go a long way to each state's plans for disaster preparedness as well. Big fan of this one. So anybody who has implemented remote physiologic monitoring or remote patient monitoring may come to a screeching halt when they realize that under Medicare, it's very specific. You can only do it for an episode of care. So I am really cautiously excited, I think is the term I would use, for the remote therapeutic monitoring codes. And I put this table together because CMS says there are two distinct differences, and I kind of pull out three. But for RPM has to be billed by physicians and non-physician practitioners, as in nurse practitioner, physician assistant, clinical nurse specialist. But remote therapeutic monitoring can be billed, is proposed, if this goes through, proposed to be billed by nurses and physical therapists and possibly others, we'll see. The RPM codes fall under E&M services, which is why other providers cannot bill under RPM. And they are categorizing the RTM codes as general medicine codes. RPM requires the data be physiologic and be digitally uploaded. Okay, so we know that, and it is a hindrance to using RPM to its fullest possibility. So RPM patients cannot do self-reported data. So if I had a patient who had a home blood pressure cuff and they were keeping their record of their blood pressures and they sent me the record, I could not bill for RPM, but RPM is an amazing tool for self-management support, keeping patients out of the hospital, keeping patients out of emergency department. It's a confidence builder for patients, but you know, clinicians and care teams are just not going to do it if they're not reimbursed. And a lot of my practices do this creatively under the chronic care management, complex chronic care management, and principal care management. But I'm really hoping that the RTM codes will help. So CMS in the proposed rule says that you can use these for health conditions, including respiratory system status, therapy, medication adherence, and therapy medication response. And as such, allow non-physiologic data to be collected. Reportedly, data also can be self-reported as well as digitally uploaded. However, it says for both sets of codes, the device must meet the FDA definition of a medical device as described in, there you go, another section and reference to something that we don't know where it is or what it says. So I am a little bit nervous about what this is going to actually look like in practice. You know, I'm always thinking about how do we operationalize this. And I did not see CMS put a cap on how frequently you, or how long you can bill the RTM codes. Like with remote physiologic monitoring, they define what an episode of care is. You can't just, it's hard to just keep kind of billing for RPM if somebody is stable. So I welcome any discussion on the RTM codes, and especially if anyone has greater insight. So the valuation of other specific codes, so the CCM, the CCM and the PCM codes. So I feel these are underutilized. I have worked with health centers and rural health clinics, RCs and SQHCs to try to get these implemented. It is a way to expand services, capture revenue, keep people out of the hospital, get paid for chronic disease management, care coordination, and care management. For some reason, this seems to be a really difficult thing to get going for people. And maybe when we stop screen sharing, I have a resource for implementing the CCM and PCM if people are interested. But so they're adding, so I keep hearing people say they're adding 5 new codes. They're actually adding 3 new codes, and they're changing 2 codes from HCPCS codes to CPT codes. So it's not that big of a deal, but I think the most important one for me is the PCM clinical staff time, you know, having those codes so that clinical staff, so by clinical staff, CMS is talking about medical assistants, LVNs, LPNs, not reception staff. They don't allow reception staff, but they are kind of opening it up so that, you know, this is how we implement team-based care, is allowing reimbursement for people who are not clinicians with NPI numbers. So I'm all for it. And yes, I have ordered my 2022 CPT code book because I want to get access to the codes and the descriptions in addition to what I can find online. So evaluation of specific codes. This is one that I think is huge. So chronic pain management can be so complex in the primary care and other settings. You know, I told you that I managed a family medicine residency, and, you know, we had new learners, and we had to be sure that we had very strict protocols for pain management. And we did. We actually had a great protocol. We built templates in our EHR, and this was back in 2006. But honestly, as a practicing primary care clinician, people who are seeking opioids it was the bane of my existence. I mean, they would lie to me. It was just devastating. I always think that people will never lie to me, and it was a little heartbreaking. So I'm really glad that for the people who really need chronic pain management, that we can do this virtually And I love that CMS said, and that's why I pulled out this quote, "We believe it is important to highlight the role of a person-centered approach to pain care." And that is true. So people with chronic pain have really seen the backlash of the opioid epidemic, and people are now really, really careful, and they don't want to give out controlled substances to control pain. And so they are creating their, if the final rule comes through as we expect it, that they'll create a separate or add-on payment for care and management for people with pain, to provide opportunities to better leverage services furnished using telecommunications technology and non-face-to-face care while expanding access to treatment for pain. This would be great. I really look forward to seeing what CMS puts together in the final rule. It's hard for people with chronic pain, and I think we have to have a lot of empathy for them. I will say that in primary care, what we do a lot, even though in some states we can do a prescription for 3 months of a controlled substance, we often will only give them 1 month at a time. And we make them physically come in and pick up that prescription just so we can get eyes on them and maybe do a drug test and have them sign paperwork and contracts and so on and so forth. And we really kind of put them through a rigmarole, and for the appropriate patients. I really look forward to this as an option for patients who are suffering. So that's, I think, about it. Let's see if I can. I did want to share with you. So, you know, all those resources that I sent, and I truly, truly wish that CMS would have a hyperlink table of contents.
That's too easy.
For the final rule. Wouldn't it be amazing? I mean, it would just be awesome. Oh, okay, so this document. So just to show you how nerdy I am, I seriously have a document called Resource Hoard, and I use my own hyperlink table of contents. So you can see I have a bunch of topics under telehealth, blah, blah, blah. And like, if we could have a hyperlink table of contents like this in the final rule, it would be amazing. Anyway, bit of an overshare. My level of nerdiness.
We're all nerds. We're all nerds. So we don't have any questions in the chat. So if anybody does have questions, please just feel free to put them there. I'm sure
I'm sorry, you all have the ability to turn your videos on. We'd love to see your faces, do a little networking here. And you have the ability to unmute yourself. So you can ask questions directly to Trudy or to Elizabeth and I. So let's hear from you.
I think that one question that might be on people's minds is, now that this is all, you know, you can submit your comments and so on. And I know at least I have, through a variety of means actually in societies that I've been involved with, because it is a rather contentious topic. Is there an expected time frame for when the final version would be there, approved, out, and, you know, people could start to use it? Or is that just sort of depending on whatever Congress feels like?
Sorry, I was reading a text, a chat, sorry. Is that in regard to the final rule, Elizabeth?
Yeah, when can we expect it to really be final and usable?
Yeah, I'm anticipating that it will be at the very end of November. There are a lot of things that are new and different in the proposed rule, and I don't know if you saw that one slide. There are 35,000 comments that have been submitted. You can go to the website. You can sort by organization. You can sort by all kinds of things. I don't know if you can sort by topic. There are 35,000 comments that they have to read through and condense. And the rules, as far as I can tell, and from what our CMS policy analyst told us, is that certain sections belong to certain people in the rules. And if you look at the beginning of the proposed rule, it'll have somebody's name and contact information, say for telehealth or for CCM or for whatever. And I expect they have to sort those and then give them to the people who have, or teams that have certain sections in the rule. And then they have to condense those and they have to include their responses in the final rule. And I think it's going to take them a while. I wouldn't be surprised if it gets pushed to the first 2 weeks of December. But I'm hoping for late November for publication of the final rule. And it'll be published in that kind of unfinished version with a bazillion thousand pages. I imagine it'll come out to 1,500 pages or more in its double-spaced form. And then it'll be published in the Federal Register. I think it's about 2 weeks later. Hey, we should start a pool. When do you think the final rule is going to be published?
No, but I do know, you know, and like I said, you can go through, and I know there's a lot of comments, but when you do go through the list and just kind of scan it, there's a ton of like really high-powered organizations that have submitted comments on a very few select topics, I think. The audio only and the requirement to see a patient in person after 6 months, I think those are the ones that are drawing the most comments. But AMA, ATA, a lot of the individual professional societies for each clinical specialty. This one more than others I've seen, like I said, there's a ton of comments, and I don't know how unusual that is to get that many, but it is very interesting. So
so question, I have a question out to everyone else. Did you submit comments on this proposed rule? And if you did, let us know. If you didn't, do you think that you will submit comments in the future?
So let's kind of hit both of them one by one, and you can use the reaction button. So if you did submit comments already, do like a thumbs up or a happy face or something under reactions. We can kind of gauge how many people are putting little emojis up. Actually, I'm not seeing a lot of emojis going up. How many of you, based on what Trudy said today, again, using that reaction button down on the bottom, are going to go out and potentially submit comments? Again, use your thumbs up or happy face or something. There's a few up there. Good. All right. Excellent. Okay.
Melanie, I love it.
That's very nice. Let's see.
So Trudy, do all comments have to be associated with an organization, or can it just be an individual?
It can be an individual, and honestly, CMS, my unofficial conversations with policy analysts say that they really, what resonates with them most is hearing from clinicians at the front lines of service delivery. So, you know, those individual stories, and I'll tell you what is like gold is for a patient to submit something with a personal story about how the change is going to impact them.
Excellent. Thank you.
Well, if we don't have any further questions, I don't see anything appearing in chat, and people are cautiously silent this morning. So if we don't have, we'll stick around for a bit more. And we Trudy, if you want to put up the last slide, please. We would appreciate you filling out a quick survey to give us some feedback and potential future topics and so on for these office hours. Again, we very much appreciate your attending today. And all of our sponsors, including the Arizona Department of Health Services in particular. So please check out our website for future events. I'm sorry, I know we don't have feedback. If you do have an interest in the specific topics for our office hours, please just email Chris or myself, and we'd be glad to put them on board. Like I said, we'll stay on for like another 5 minutes in case people do have questions. But again, this program has been sponsored by the Southwest Telehealth Resource Center, the Northwest Regional Telehealth Resource Center, the Arizona Telemedicine Program, and the Arizona Department of Health Services.